Hi guys, Ollie here. Today I'm going to be talking to you about what happens during an initial assessment. So as always, we're going to leave it about 30 seconds and then we're going to get right into the video. Cool. Okay, so I've had a lot of people recently ask me about the process, what actually happens when you come into clinic. How do we get the rehab started? So it's really important when we start off with a new patient to always take a thorough, what we call an initial assessment. In our initial, we go over lots of different things. We try and break it up into two main parts. So we've got the subjective and the objective. So the subjective is always going to be the talking stage. So we're going to find out all about what's occurred up to the point which brought you into clinic. And then what we do after that is we go into some testing. So we look at the objective view, which basically means we're going to have, I'll have a look myself and see if I can find anything. And I'm going to break down what these two parts really consist of. But it's also important to note that in our sessions, the way that we do it within On Your Game is we always split our sessions into two, okay? So our first initial appointment is going to be the subjective and objective. And from the information we take from that session, we then turn it into a plan. And in our second session that we have together, we walk you through the plan, and that's when we come up with how many, how much we need to see you, how many sessions we're gonna need to treat the injury or the problem. But it all comes from that first session, that initial appointment that we have together, because then we get an understanding of what's actually occurred up to that point and see how bad the problem is. So we can then come up with an effective plan to then make sure you're on your right stages of recovery and you can get fixed as soon as possible. So first of all, let's talk about this subjective assessment. When you come and sit down, the first things that we're usually going to ask you is, so what's brought you in today? And in that, we're going to ask the location of the injury, what happened to cause the injury. We can look at the different types of pain that you're experiencing due to the injury. We see a lot of, it's either going to be like a sharp pain, you can get referred pain, you can get these dull aches as well. And by the therapist asking these questions, it just builds a deeper understanding of what's occurring. We should be able to already, by the end of the subjective stage, have a good understanding of what's occurring and what the injury is before we even get into testing. But to be able to do that, we have to ask lots of questions to be able to develop the knowledge of the injury. And that's why it's important to know, how long the injury's been occurring for, if it was a recent flare-up, if it was one big collision maybe. So, if we're looking at in sporting terms, you could have had a game on the weekend playing whatever sport you play, and something could have occurred from that. Equally, you could have had chronic pain where you've had, we see quite a lot of lower back patients who've been suffering from quite a significant amount of pain for a while. And this just gives us an understanding of where we need to start from in terms of the plan and what we need to do moving forward as well. So some other questions you might hear us ask as well is there anything that aggravates the injury? Is there anything that you do in a day-to-day, in your day-to-day life, which is actually making the injury worse for you? You can also look at what makes it better. So if there's any home remedies that you've tried already, which you thought, actually, no, this has been really beneficial. So we see a lot of patients who say, actually my injury I find it actually eases after walking. Some patients will say to us that no, actually walking makes it worse. Some people like to rest their injuries. They find that just keeping it still really helps. And some people find that actually keeping whatever the injury may be moving really helps as well. And this is just all giving me an understanding of what's occurred and what we can do in forms of treatment to actually make you feel better as well. And then some more really important questions that we ask as well is definitely the pain level. So we use something called the visual analog scale, which is something that I always ask all my patients. And what that basically means is we get you to rank your injury on a scale of 0 to 10 of how extreme the pain feels for you. And we usually ask it in three ways. We say at its best, where is this injury? Where would you put it on that scale? At its worst, where would you put the pain scale? And also currently, so you sitting down with me right now, where are you feeling that pain level is? And then what we do is we can look at the history of the condition as well. So we can see if the injury is repetitive, so if it's something that keeps on flaring up, if it's something that's just come on all of a sudden, if there wasn't even a cause for the injury, if it just came on all of a sudden, you don't know how that happened. We've also got to consider what the trauma was, how significant the trauma was, if it was at high velocity, so if you're in a football game and you've just gone smacking into someone. What type of sport do you play as well? So if it was a netball injury as opposed to a rugby injury, we usually see a lot of non-contact injuries within netball, whereas rugby is obviously going to be quite high contact. You see a lot of concussions, stingers, things that you need to have a collision for an injury to occur like that. And then we'll always ask, is this problem getting worse? Are you finding that actually since the injury's occurred, is it getting gradually worse? Is it getting better? What we don't want to do is we never want to ask leading questions. We always want you to come up with the answer that you see fit. So we never want to put answers into your head, which I know I've definitely been accustomed to doing on occasion, where I might ask someone, so it's quite a bad injury then, is it? Which isn't the right sort of question we should be asking. It's very much a subjective point of view from your side, where we want to find out what your feelings are about the injury. And then going on as well, we always need to ask you what your feelings are about the injury. Have you got any expectations maybe for what's going to occur within physio? Have you got any questions about what's going to occur with the plan? Because we've had it so many times before where people have a different understanding to what physio is as opposed to what will actually occur. And that's due to mainly past experiences as well. So we have a lot of patients who tried out different physios and different sports therapists as well, and they've had different expectations due to that as well. So we see a lot of NHS patients who've tried NHS before, and then they've come to see us, and the way that those sessions work is definitely very different. You get a lot of either shorter sessions, or they won't be as in-depth, whereas we can offer you obviously a much more in-depth plan where we get to see you more regularly. And also we get to do a lot more because of the gym, obviously, that we use downstairs if you've been into our clinic. Some other things that we could ask you is sleep. Has that been affected? Because what we'll see is usually with if sleep's been affected, and that's going to affect the stress hormones, which I spoke about in a previous live before, which may actually make the pain feel worse, even though the injury itself isn't getting worse. And if the sleep's obviously been affected, then we're talking about healing stages, where you're not going to be able to heal up as quickly. And we could also ask you about your job as well, what you do in your day-to-day. That would also have a massive impact on what the injury looks like, if it's getting worse, if it's getting better. If we're, for instance, in a very active job where we've got to use our body and we've got a knee injury, then that pressure being put through the knee isn't going to make it feel any better, and that for the most part will make it actually worse. So we'll have to modify the sessions when we do get into the rehab around what you're working as well. Another thing that we could say is we could ask about if there's been any other previous trauma to the place, to the injury, because that will obviously have an impact on this new flare-up, or if it's happened again, then we can work around that as well. Cool. Okay. What some other things that are really important when we think about an injury is also past medical history. So even though we have this new injury that's occurred, are you suffering from any health issues? What's your general health looking like? It could be very black and white, where we could actually say, look at like factors like weight, age, which will obviously play a factor. We could also look at problems such as thyroid, heart, if you've been diagnosed with rheumatoid arthritis, epilepsy, asthma. These are all factors that we need to take in when coming up with an effective rehab plan. If we were to deal with someone with, let's say, asthma, then we wouldn't expect to push you as hard as someone obviously without asthma, and therefore we'd maybe take a bit longer through the rehab just to work around your needs. And also we could look at different surgeries that have occurred, any major illnesses that you've had. Obviously COVID's been a big thing that's happened in the past few years, so if we can get all of these facts and we can put it into a plan, it's going to make our life so much easier. So the longer and the more information we get from the subjective, the better the rehab plan's going to be for you moving forwards. Now, going back to our social history, so this is going to be our job, for instance. It's also going to be what you do maybe on the weekends, what your lifestyle looks like. Are you smoking? Are you drinking excessively? What are your living circumstances like? Who do you live with? If you live with children, for instance, then are you constantly picking up your children? I know I've seen a lot of people in clinic recently who've suffered from upper trap and neck issues due to the fact that they have to pick up their children constantly, and then therefore because of that the injury is actually getting worse as a result. So these are all things that we need to get into the plan so we can work around it. And maybe we can also look at not just doing the exercises with you, but talking to you about how to effectively manage your day to stop the injury from getting worse and to stop yourself from feeling this intense pain. After we've got that good subjective assessment, we can then look to go into our objective assessment. So now I've got an idea of exactly where the injury is, what's happened, how bad the pain is. We can then look to start our testing, and we always start our testing firstly with an observation. So let's say it was to be a knee injury. We could have a look at the knee itself. When we look at the knee, we look for swelling, we look for discoloration, we look for Q angle, which is the angle your hips are going and your femur is directed at. So if ladies usually have a wider hip angle, wider Q angle I should say, because the hips are wider. If your hips are wider, then that's going to put more pressure medially through the knee. We could also look at if there's been any atrophy to the area. If one leg's bigger than the other, that will give us a good indication of how long the injury's been occurring for. So obviously if we've got a patient in who's torn their ACL, we expect to see some atrophy at the leg due to the fact that they wouldn't be able to use it. A really good way that we can monitor this as well is we can just take a tape measurement of the diameter of the leg at the thigh at its thickest point and also at the calf at its thickest point as well. And we can see how much muscle loss has occurred. And then we can measure that through our plan, and we can see and show you exactly where we're improving and how quickly we're improving as well. We could also look for any other abnormalities. So if there's anything else, if we see any scarring, if we see any lumps, anything that shouldn't be there. We can also look at the patella if we're looking at the knee. Obviously, if we're looking at the shoulder, some things we could look out for is shoulder height discrepancy, which basically just means one shoulder is sitting higher than the other. If we're looking from the back, we can see some scapular dyskinesis. We could see the scapular winging, so one shoulder blade sticking out further than the other. And these are all factors which are going to be at play as to why the injury is hurting you so much. After we've looked at the injury itself, we'll then take a broader picture of the injury. We can have a look at your posture. We usually have a look at that from standing and sitting, so we can have a really good understanding of where it's affecting you. For instance, if it was to be back pain and you were to stand up and we were slightly crooked, we could see that there's some muscles obviously at play there which are pulling and causing this tightness, which is then caused, it could be a scoliosis, it could be kyphosis, any rounding of the back. But we could also have a look at you sitting as well and see if actually it's sitting and your seating position that's causing issues as well. The reason that the sitting position is so important as well is most of us will spend a lot of our lives sitting at a desk, on a chair, maybe at school, at university. If you're just sitting on the sofa all day, then we need to see what that position looks like, because we need to know where the injury's been affected. Yeah, so it's just asymmetry, and then as I said, kyphosis, which is rounding of the mid portion of the back, lordosis, which is excessive rounding of the lower back, and that's very specific to obviously back pain, but we could do the same thing for shoulder as well, as I explained to you. If there's scapular dyskinesis, which is just the shoulder blade sticking out, or any other issues. If it's at the knee, we can see if you're putting bend in your leg. If your feet, we can have a look at your foot position as well. If you're everted, inverted, if you haven't got an arch, this Q angle that I was explaining to you earlier as well. They all play a factor into why the injury might have occurred and might still be hurting you as well. After we've had a look at the posture, what we'll tend to do next is we'll go through our range of motion, which is if we imagine the arm, so imagine the elbow, we've got two main types, I should say, of range of motion at the elbow. We've got flexion, extension. So that would be one thing that we would look at as well. We do that in two ways. We look at it passively and actively as well. So we'll do passive, basically means I will do the movement for you. So I will bend your arm and see how much range of motion we can get. We usually take a goniometer at this point and measure the actual angle of the affected limb compared to the good side, just so we can see how quickly you're progressing. With different plans, we will need to reach a certain range of motion to be able to move on to the next stages of physio, which I will get onto later. But after we've looked at the passive range of motion, we will then go into our active range of motion, which is you doing the movement yourself. So it will just be flexion, extension, and we'll just see how that looks from side to side, see if there's any differences, see where the pain kicks in. If you're getting pain at the end of range, then we can obviously take this into account and we can modify the plan due to this as well. So yeah, we will look at the range of motion next. What are the other things I missed out? Oh yeah, and we can also look at not just if it's hurting your end of range, if there's any stiffness, so if it's difficulty getting to a certain range. If we were talking about something like frozen shoulder, we would expect to see, the end range around here, and it would be a lot of pain and a lot of stiffness. We could also look at the limiting factors as well. So if there's anything else that's stopping it, maybe if there was a lump or something which is stopping you from getting the end of range, we'll be able to take a look at that and see exactly what's going on there. So yeah, after we've had a look at the range of motion, we then move on to our myotomes, which is our muscle strength. So we do the same thing. And we'll look at the amount of power you can generate from your good limb to your bad sides. I'll give the example of the shoulder here. So if we're looking at the shoulder, we've got flexion coming forward, extension going backwards, we've got abduction coming out to the side, we've got adduction, bringing your arm inwards. We also have external rotation, which is bringing your arm upwards like this, or you could do it in this angle as well if this is causing you too much pain. And we also have internal rotation, which is bringing your arm downwards like that. As you see, I don't have a lot of internal rotation myself. But what we'll do is after we've done the range of motion, we will then look at testing the strength levels through each of those ranges of motion, so we can see what muscles are affected, or if there's something underlying, maybe in the joint capsule itself. We can usually get a good understanding from muscle testing. Yeah, so then we've done our muscle testing. What we're going to look to next is we could do something called special testing, which is specific tests for certain diagnosis. For instance, I will give the example of if we're looking at the knee and we've got some knee pain, if we've just had a heavy trauma to the knee, usually we'll see this in a sporting activity. We can actually test, we have these things called special tests, which test for each individual ligament. We can test for meniscus as well. And basically we'll do all of these. So if I've come to the understanding from the subjective and the objective testing that we've performed so far that this could be a ligament injury, we will go through ligament testing after we've done our strength testing and our range of motion. And we can then get a better understanding of what the injury is, and we can really give you a diagnosis for what that injury is. Another example of a neuro test, for instance, is if you are suffering from shooting pain down the leg, and you can feel it from your glute into your hamstring, into the side of your leg. This is usually a strong indication that you're dealing with sciatica, and the way we can test that is by doing something called the slump test, which basically puts your sciatic nerve on a stretch. And if your pain increases from performing the slump test, that will give us an understanding that you are dealing with sciatica. So that's what we would go through from an objective side. So now we've taken the subjective and the objective. Now what we do with this out on your game is we come up with a plan for you. Okay, so we take all this information, we book in another session, and in the second session that we have together, we go over what the most effective form of treatment will be for you. Without an understanding from the first assessment, we wouldn't know obviously how many sessions we need to see you, how many times a week we need to see you, if we can give you a diagnosis of what the problem is, obviously. But what we do is we come up with that plan first, so we can eloquently describe it to you and exactly what needs to happen for you to get better and for you to make yourself back to 100 or get yourself back to 100%. So what I was going to do is go through one of my patients that I've got currently and explain to you the what happened during the diagnosis and the initial assessment and what plan we got them on. So excellent, cool. Okay, so my patient came in with anterior knee pain, and they had suffered an injury in a football game. It was a highly traumatic injury. They heard a snap. Luckily for me, they went to the hospital and they got an MRI. They heard a snap at the knee, at the right knee. And luckily for me, so we already had the diagnosis there because we were able to get this MRI, we were able to get a scan to the injury. Now, from this, it was only happened 2 weeks ago. Now, luckily for us, we tend to have lots of different papers and studies that have been done to show the most effective ways for certain injuries to recover from. So, luckily for him, we got him onto an ACL plan that I use. This ACL plan has been made by a very smart man. I will tell you his name, Matthew Buckthorpe, who is the head of the FIFA Medical Centre of Excellence in London in the UK. And he has come up with a 10-stage plan that we work through with this patient. And what it consisted of is, firstly, was to get him back to walking. So that's really important. Now, what we do for the walking is, because obviously after the injury, he went straight onto crutches. Walking consists of a regular walking gait with good quad recruitment, and is able to walk with no limp, unaided. Okay, so that's what we need to hit to be able to move on to the next stage. Okay. After we had him walking, we were then able to move on to what we call bilateral foundation movements. This is basically a squat, and what we need to get to is, for the second stage to be complete, is we had to get him to a squat at 90 degrees with less than 20% asymmetry and limb loading. What this means is we are looking for a perfectly symmetrical squat, so we didn't want him twisting out to the side one way or another. We needed the patient to be exactly level, coming down with at least 20% leeway. Okay. Now, what we did after the getting him to squatting, and I should say the way we did this is we built up a lot of isometric strength. So we did wall sits at a quarter squat angle. We did some quarter squats. We did some leg extensions. We worked on getting full range of motion back through extension, which is something that a lot of people struggle with when it comes to ACL injuries. And after we did that, then we can move on to unilateral foundation movements, which is a single leg squat pretty much. And it just meant that we could then start our balancing phase. So working isometrically through one leg, working through bent leg, squatting, through bent leg holds of like an isometric hold pretty much. And basically what I'm trying to say is we go through different phases, and what we can do is we can show you with this plan exactly where we need to get to and where we're at currently. So within our sessions, we will always put in a session where we can talk to you about what the different stages are going to be coming up next. We can talk to you about what the next level of the plan is going to be, until we get you to the finishing point. And yeah, so that's why it's really important to have the 2 sessions. I hope you learned something new today. If you've already been into clinic and you've experienced this, then let me know, and let me know how the plan was for you. Equally, if you're looking to come into clinic, please come in. There's lots of spaces available, so we'd love to have you in. But yeah, lovely speaking to you guys. If you have any questions, please pop them in the comments. Yeah, thank you very much.